Question 1. Upon reviewing recent clinical trial outcomes related to the effectiveness of positive pressure ventilation techniques in term neonates, a certified neonatal resuscitation program, provider notes findings that appear to differ from the current NRP guidelines they were trained under. Which of the following represents the most appropriate and compliant next step for this provider? Option A. Immediately incorporate the new techniques into their practice, as clinical trial data supersedes existing guidelines. Option B. Consult the most recent official neonatal resuscitation program, educational materials, and updates to understand how these trial outcomes have been evaluated and integrated into current NRP recommendations. Option C. Independently research the primary sources of the clinical trials and begin practicing the new techniques based on their personal interpretation of the data. Option D. Discuss the trial findings with colleagues and implement any consensus reached among the group, regardless of official NRP guidance. The correct answer is A. Immediately incorporate the new techniques into their practice, as clinical trial data supersedes existing guidelines. Explanation. The scenario presents a common challenge in evidence-based practice, integrating new research findings into established protocols. Neonatal resuscitation is a dynamic field, and staying abreast of the latest clinical trial outcomes is crucial for providing optimal care. The professional challenge lies in discerning the validity and applicability of new evidence, especially when it potentially contradicts or modifies current best practices. This requires critical appraisal skills and a commitment to continuous learning within the strict confines of the Neonatal Resuscitation Program, NRP, guidelines. The correct approach involves a systematic and evidence-based review process, adhering to the principles outlined by the NRP. This means consulting the official NRP materials, which are developed by experts and reflect the consensus of current best practices informed by rigorous scientific review. When new evidence emerges, the NRP process itself dictates how it is evaluated and incorporated. Therefore, seeking out the most recent NRP updates and educational materials is the most direct and compliant way to understand how new clinical trial outcomes have been integrated into the program's recommendations. This approach ensures that any changes in practice are based on a thorough, expert-led evaluation of the evidence, aligned with the program's established quality assurance and dissemination mechanisms. An incorrect approach would be to independently adopt practices based solely on a single clinical trial or a summary from a non-NRP sanctioned source. This fails to acknowledge the rigorous consensus-building process that underpins the NRP. Relying on anecdotal evidence or personal interpretation of research bypasses the established channels for evidence dissemination and can lead to the adoption of practices that are not yet validated by the NRP or, worse, are contrary to its recommendations. This poses a significant ethical and professional risk, as it deviates from the standardized, evidence-based curriculum designed to ensure consistent and effective neonatal resuscitation across all certified providers. Such a deviation could compromise patient safety and violate the principles of adhering to approved educational standards. Professionals should employ a decision-making process that prioritizes adherence to the official NRP guidelines. When encountering new research, the first step should always be to consult the latest NRP textbook, online modules, and instructor resources. If a specific clinical trial outcome appears to contradict current NRP recommendations, the professional should seek clarification through official NRP channels, such as the NRP Steering Committee or educational representatives, rather than implementing changes unilaterally. This ensures that practice remains aligned with the most current, evidence-based, and officially sanctioned resuscitation guidelines. Question 2. Strategic planning requires a clear understanding of the most critical initial interventions for a term neonate born at NAIC with a heart rate of 50 beats per minute and poor tone. Which of the following actions should be the immediate priority? Option A. Begin chest compressions. Option B. Initiate positive pressure ventilation. Option C. Assess for meconium staining. Option D. Administer epinephrine. Correct answer is B. Initiate positive pressure ventilation. Explanation. This scenario is professionally challenging because it involves a critical, time-sensitive situation where immediate, effective intervention can significantly impact the neonate's outcome. The pressure of a rapidly deteriorating infant, coupled with the need for coordinated team action, demands swift and accurate decision-making. The importance of immediate care in neonatal resuscitation is paramount, as delays can lead to irreversible hypoxic injury. The correct approach represents best professional practice by prioritizing the initiation of positive pressure ventilation, PPV, as the first step in resuscitation when the neonate is apneic or gasping and has a heart rate below 100 beats per minute. This aligns directly with the Neonatal Resuscitation Program, NRP, guidelines, which are the sole regulatory framework for this exam. NRP emphasizes that PPV is the most critical intervention to improve oxygenation and ventilation, thereby supporting cardiac output and preventing further deterioration. Promptly initiating PPV addresses the primary physiological derangements in a depressed neonate. An incorrect approach that delays or omits PPV, such as focusing solely on chest compressions without first ensuring adequate ventilation, represents a significant regulatory and ethical failure. The NRP guidelines clearly stipulate the sequence of interventions. Chest compressions are indicated only if the heart rate remains below 60 beats per minute despite effective PPV for 30 seconds. Delaying PPV in favor of chest compressions when ventilation is the primary issue is a direct violation of established resuscitation protocols and compromises patient safety. Another incorrect approach might involve administering medications like epinephrine before establishing effective ventilation, which is also contrary to NRP guidelines. Medications are secondary to airway and breathing support. Failure to adhere to these established protocols constitutes a breach of professional standards of care and can lead to adverse patient outcomes, which is ethically unacceptable. The professional decision-making process for similar situations should involve a rapid assessment of the neonate's condition based on established NRP criteria: tone, breathing, heart rate. The team leader must then clearly direct the appropriate initial intervention, which in this case is PPV. Effective communication and clear roles within the resuscitation team are crucial. If the initial intervention, PPV, does not yield the desired improvement in heart rate, the team must systematically reassess and proceed to the next step in the NRP algorithm, such as considering chest compressions or reassessing ventilation effectiveness. This systematic, algorithm-driven approach, grounded in the NRP guidelines, ensures that the most critical interventions are performed in the correct sequence and at the appropriate time. Question 3. Examination of the data shows a newborn delivered at 36 weeks gestation to a mother with preeclampsia and who received intrapartum antibiotics. The infant is born with good tone, crying vigorously, and has a heart rate of 140 beats per minute. Which of the following actions best reflects the initial management of this newborn according to Neonatal Resuscitation Program guidelines? Option A. Provide positive pressure ventilation immediately due to the history of prematurity and maternal preeclampsia. Option B. Initiate chest compressions and administer epinephrine due to the potential for intrapartum infection. Option C. Perform a rapid, thorough physical examination to assess tone, breathing, and heart rate, and if all are reassuring, proceed with routine care. Option D. Place the infant under a radiant warmer and observe for 30 seconds before any intervention. The correct answer is A. Provide positive pressure ventilation immediately due to the history of prematurity and maternal preeclampsia. Explanation: this scenario is professionally challenging because the identification of high-risk newborns requires a multifaceted approach that integrates clinical assessment, maternal history, and real-time fetal monitoring data. The urgency of the situation, coupled with the potential for rapid deterioration in a neonate, necessitates swift and accurate decision-making. Failure to correctly identify a high-risk infant can lead to delayed or inappropriate resuscitation efforts, with potentially devastating consequences for the infant's health and survival. The correct approach represents best professional practice because it aligns with the core principles of the Neonatal Resuscitation Program, NRP, certification, which emphasizes a systematic and evidence-based approach to neonatal resuscitation. This involves a thorough assessment of the infant's condition at birth, considering all available risk factors, and initiating appropriate interventions promptly. Adherence to NRP guidelines ensures that all members of the resuscitation team are working from a common understanding and employing standardized techniques, thereby maximizing the chances of a positive outcome and minimizing preventable harm. This approach is ethically mandated to provide the highest standard of care to vulnerable newborns. An incorrect approach that relies solely on the presence of a single risk factor, such as prematurity, without considering other crucial indicators like the infant's tone, breathing effort, and heart rate, is professionally unacceptable. This narrow focus can lead to overlooking other significant risk factors or misinterpreting the infant's overall condition, potentially delaying necessary interventions. Another incorrect approach that involves waiting for definitive signs of distress before initiating resuscitation is also professionally unacceptable. NRP guidelines stress proactive assessment and intervention based on identified risk factors and initial assessment, rather than a purely reactive stance. This delay can result in irreversible hypoxic injury. A third incorrect approach that involves delegating the primary assessment of risk to a less experienced team member without direct senior supervision is ethically and professionally problematic, as it compromises the quality of care and potentially exposes the infant to suboptimal management. Professionals should employ a decision-making framework that begins with a comprehensive review of maternal and fetal history, followed by an immediate, hands-on assessment of the newborn upon delivery. This assessment should systematically evaluate tone, breathing, and heart rate, integrating these findings with any known risk factors. The team should then collaboratively determine the infant's risk status and the appropriate initial steps, adhering strictly to the NRP algorithm. Continuous reassessment and clear communication among team members are paramount throughout the resuscitation process. Question 4. Performance analysis shows that during initial newborn assessments, there is variability in how the APGAR score is documented. Which of the following approaches best reflects adherence to the Neonatal Resuscitation Program, NRP, guidelines for initial assessment and scoring? Option A. Assign an APGAR score based on the overall appearance of the infant, assuming a healthy term infant will generally score well. Option B. Perform the APGAR assessment after all initial stabilization procedures are completed to ensure the infant is stable before scoring. Option C. Document an APGAR score that reflects the desired outcome for the infant, rather than the immediate objective findings. Option D. Systematically evaluate each of the 5 APGAR components: heart rate, respiratory effort, reflex irritability, muscle tone, and color at 1 and 5 minutes of life, documenting the objective findings for each component to derive the total score. The correct answer is D. Systematically evaluate each of the 5 APGAR components: heart rate, respiratory effort, reflex irritability, muscle tone, and color at 1 and 5 minutes of life, documenting the objective findings for each component to derive the total score. Explanation. Scenario analysis. This scenario is professionally challenging because it requires immediate, accurate assessment and documentation of a newborn's condition immediately after birth, under high-pressure circumstances. The APGAR score is a critical tool, but its application demands objective observation and a clear understanding of the scoring criteria, especially when subtle signs might be present. The challenge lies in distinguishing between normal physiological responses and signs requiring intervention, and then translating these observations into a standardized score that effectively communicates the infant's status to the entire healthcare team. Correct approach analysis. The correct approach involves a systematic, objective assessment of the 5 APGAR components: heart rate, respiratory effort, reflex irritability, muscle tone, and color at both 1 and 5 minutes of life. This aligns with the Neonatal Resuscitation Program, NRP guidelines, which emphasize standardized assessment for timely and appropriate resuscitation. Accurate scoring ensures that the infant's needs are correctly identified, facilitating prompt and effective management, and providing a baseline for subsequent assessments. This objective approach is ethically sound as it prioritizes the infant's well-being through evidence-based practice and ensures clear communication among caregivers. Incorrect approaches analysis. One incorrect approach would be to estimate the APGAR score based on the overall impression of the infant without systematically evaluating each component. This is ethically problematic as it deviates from the standardized NRP protocol, potentially leading to an inaccurate assessment and delayed or inappropriate interventions. Fails to meet the professional obligation of providing objective, evidence-based care. Another incorrect approach would be to delay the APGAR assessment until after initial stabilization measures are completed, if those measures were not directly indicated by the initial assessment. This is a regulatory failure as NRP mandates assessment at specific time points, 1 and 5 minutes, regardless of initial interventions, unless those interventions are part of immediate resuscitation. Delaying the score can obscure the infant's initial status and hinder the evaluation of the effectiveness of any resuscitation efforts. A third incorrect approach would be to document a score that is influenced by personal bias or a desire to present a more favorable outcome, rather than reflecting the objective findings. This is a severe ethical and professional failure, undermining the integrity of the medical record and potentially compromising future care by providing misleading information. It violates the principle of honesty and accuracy in patient care documentation. Professional reasoning. Professionals should approach APGAR scoring with a mindset of objective observation and adherence to the NRP protocol. This involves understanding the specific criteria for each component and applying them consistently. When faced with ambiguity, it is crucial to consult with colleagues or refer to NRP guidelines. The decision-making process should prioritize the infant's immediate and ongoing needs, ensuring that the APGAR score serves its intended purpose as a communication tool and a guide for further management. Question 5. The monitoring system demonstrates a consistent heart rate of 50 beats per minute despite ongoing chest compressions and ventilation. The chest recoil appears adequate, and the compression rate is within the recommended range. However, the palpable femoral pulse remains weak and difficult to elicit. What is the most appropriate next step in managing this neonate's resuscitation? Option A. Administer a bolus of intravenous fluid to improve circulation. Option B. Increase the rate of chest compressions while maintaining the current depth. Option C. Immediately discontinue chest compressions and focus solely on ventilation. Option D. Adjust the technique to ensure adequate compression depth and reassess the pulse. The correct answer is D. Adjust the technique to ensure adequate compression depth and reassess the pulse. Explanation. This scenario presents a common yet critical challenge in neonatal resuscitation, recognizing and responding to inadequate chest compressions. The professional challenge lies in the rapid assessment of the neonate's condition, the accurate interpretation of physiological data, and the timely, effective implementation of resuscitation interventions. The pressure of a life-threatening situation demands precise adherence to established protocols to optimize the neonate's chances of survival and minimize potential harm. The correct approach, which involves adjusting the compression technique to achieve adequate depth and rate, represents best professional practice as it directly addresses the physiological need for effective circulation. Neonatal Resuscitation Program, NRP guidelines, which are the sole regulatory framework for this exam, emphasize the importance of compressions that are deep enough to generate a palpable pulse and a rate that ensures adequate cardiac output. Failure to achieve these parameters renders compressions ineffective, potentially leading to irreversible organ damage or death. Adhering to NRP guidelines ensures a standardized, evidence-based approach to resuscitation, promoting optimal patient outcomes. An incorrect approach that continues compressions without assessing or adjusting for depth and rate is a significant regulatory and ethical failure. This demonstrates a lack of critical assessment and adherence to NRP protocols, which mandate reassessment of compression effectiveness. Continuing ineffective compressions violates the ethical principle of beneficence, as it fails to provide the necessary life-saving intervention. It also represents a failure to uphold professional competence by not applying learned resuscitation skills appropriately. Another incorrect approach, such as immediately discontinuing compressions without attempting to improve their quality, is also professionally unacceptable. This could be due to misinterpreting the data or a lack of confidence in applying corrective techniques. This failure to persevere with appropriate interventions, as outlined by NRP, can lead to a missed opportunity to establish circulation. The professional decision-making process for similar situations should involve a systematic, protocol-driven approach. This includes 1. Continuous assessment of the neonate's response to interventions, including vital signs and perfusion. 2. Accurate interpretation of monitoring data in the context of the neonate's overall clinical picture. 3. Prompt and decisive action based on established NRP algorithms, including reassessment and adjustment of interventions when initial efforts are not yielding the desired results. 4. Effective communication and teamwork with other members of the resuscitation team. Question 6. Analysis of the most effective method for monitoring a neonate's heart rate and oxygen saturation during resuscitation, considering the need for continuous, real-time data to guide interventions and assess response, leads to the following consideration. Option A. Utilizing a cardiotachograph, CTG, for continuous heart rate monitoring and intermittent spot checks of oxygen saturation with a pulse oximeter. Option B. Using a pulse oximeter with a properly placed sensor for continuous oxygen saturation monitoring and auscultating the apical pulse for continuous heart rate assessment. Option C. Employing a precordial stethoscope for continuous heart rate assessment and relying on visual assessment of skin color for oxygenation status. Option D. Implementing continuous cardiac monitoring via ECG leads for heart rate and a properly placed pulse oximeter for continuous oxygen saturation monitoring. Correct answer is A. Utilizing a cardiotachograph, CTG, for continuous heart rate monitoring and intermittent spot checks of oxygen saturation with a pulse oximeter. Explanation. The scenario presents a common challenge in neonatal resuscitation, ensuring accurate and timely assessment of a neonate's cardiorespiratory status when multiple monitoring modalities are available. The professional challenge lies in selecting the most appropriate method for heart rate and oxygen saturation monitoring that aligns with established neonatal resuscitation program, NRP, guidelines, ensuring patient safety and optimal care delivery. The urgency of resuscitation demands efficient and reliable data acquisition. The correct approach represents best professional practice because it prioritizes the use of a method that provides continuous, real-time data for both heart rate and oxygen saturation, as recommended by NRP guidelines. This allows for immediate assessment of the neonate's response to interventions and guides further management decisions. Adherence to NRP guidelines is a core ethical and regulatory requirement for healthcare professionals involved in neonatal resuscitation, ensuring a standardized and evidence-based approach to care. Incorrect approaches fail to meet the standards set by NRP guidelines and may compromise patient care. Relying solely on intermittent palpation of the pulse, for instance, is insufficient for continuous assessment and can lead to delayed recognition of critical changes in heart rate. Similarly, using a pulse oximeter without ensuring proper placement or calibration can yield inaccurate readings, leading to misinterpretation of the neonate's oxygenation status. Failure to integrate both heart rate and oxygen saturation monitoring, as per NRP recommendations, represents a deviation from best practice and can be considered a regulatory and ethical lapse, potentially impacting patient outcomes. The professional decision-making process in such situations should involve a systematic evaluation of available monitoring tools against the current NRP guidelines. This includes understanding the limitations of each method and prioritizing those that offer continuous, reliable data for both key physiological parameters. When faced with uncertainty, consulting with experienced colleagues or referring to established protocols is crucial. The ultimate goal is to ensure that monitoring practices directly support effective resuscitation and improve the neonate's chances of a positive outcome. Question 7. Compliance review shows a newborn infant is crying vigorously and has good muscle tone immediately after birth. However, the attending nurse expresses concern that the infant may still require some form of respiratory support due to subtle changes in skin color. Which of the following actions best reflects the immediate physiological assessment and management priorities for this newborn, according to Neonatal Resuscitation Program, NRP guidelines? Option A. Administer supplemental oxygen via a mask without assessing heart rate or respiratory effort. Option B. Initiate positive pressure ventilation immediately to address the concern about skin color. Option C. Perform a rapid assessment of the infant's heart rate and respiratory effort, and if both are adequate, continue routine care while observing for further changes in color. Option D. Focus solely on improving the infant's skin color by rubbing the infant vigorously. The correct answer is B. Initiate positive pressure ventilation immediately to address the concern about skin color. Explanation. The scenario presents a common challenge in neonatal care, recognizing and responding to the physiological transition a newborn undergoes at birth. This transition is critical, as failure to adapt can lead to significant morbidity or mortality. The challenge lies in distinguishing normal adaptive changes from signs of distress requiring intervention, demanding a thorough understanding of neonatal physiology and the ability to apply this knowledge rapidly in a high-stakes environment. The correct approach, which involves assessing the infant's respiratory effort, heart rate, and color, directly aligns with the core principles of the Neonatal Resuscitation Program, NRP. NRP guidelines are based on extensive research and clinical evidence to ensure the most effective and evidence-based resuscitation efforts. This systematic assessment allows for the identification of infants who require positive pressure ventilation or chest compressions, thereby preventing adverse outcomes. Adherence to NRP protocols is a regulatory requirement for healthcare providers involved in neonatal resuscitation, ensuring a standardized and safe approach. An incorrect approach might involve delaying intervention based on a subjective feeling that the infant will improve on its own. This is a significant regulatory and ethical failure because it deviates from established NRP protocols, which mandate a structured assessment and timely intervention based on objective criteria. Such a delay could lead to irreversible hypoxic injury. Another incorrect approach could be to focus solely on one parameter, such as only observing breathing, without assessing other vital signs like heart rate. This is also a failure of NRP guidelines, which emphasize a comprehensive assessment of multiple physiological parameters to guide resuscitation. Over-reliance on maternal history without a direct infant assessment is another failure, as the infant's condition at birth is paramount and may not directly correlate with prenatal information. Professionals should employ a decision-making process that prioritizes immediate, objective assessment based on established guidelines. This involves a systematic review of the infant's condition using the NRP flow diagram, which guides the provider through a series of steps based on the infant's response to initial measures. This structured approach ensures that all critical physiological parameters are evaluated and that interventions are initiated promptly and appropriately, minimizing the risk of adverse outcomes and ensuring compliance with best practices and regulatory standards. Question 8. The performance metrics show a consistent pattern of inadequate duration of chest compressions during neonatal resuscitation efforts, following a period of positive pressure ventilation that has not resulted in an improved heart rate. What is the most appropriate next step according to the Neonatal Resuscitation Program, NRP, guidelines? Option A. Immediately initiate chest compressions coordinated with positive pressure ventilation. Option B. Continue positive pressure ventilation for an extended period, reassessing the heart rate every minute. Option C. Administer epinephrine intravenously without further assessment of ventilation or heart rate. Option D. Reassess the effectiveness of positive pressure ventilation, and if the heart rate remains below 60 beats per minute, begin chest compressions. The correct answer is A. Immediately initiate chest compressions coordinated with positive pressure ventilation. Explanation: scenario analysis. This scenario is professionally challenging because it requires immediate, high-stakes decision-making under pressure, where the infant's life is directly impacted by the chosen resuscitation strategy. The challenge lies in accurately assessing the infant's condition and selecting the most appropriate intervention from a range of possibilities, all while adhering to established NRP guidelines. The performance metrics indicating a lack of sustained chest compressions highlights a critical gap in the team's ability to maintain a fundamental resuscitation technique, which can lead to suboptimal outcomes. Correct approach analysis. The correct approach involves a systematic reassessment of the infant's response to positive pressure ventilation, PPV, and a prompt initiation of chest compressions if the heart rate remains below 60 beats per minute despite adequate ventilation. This aligns directly with the Neonatal Resuscitation Program, NRP, algorithm, which prioritizes effective ventilation as the primary step. If ventilation is adequate and the heart rate does not improve, chest compressions are indicated to improve systemic circulation. This approach represents best professional practice because it is evidence-based, follows the established NRP guidelines, and prioritizes the most effective interventions for improving the infant's cardiorespiratory status. Adherence to the NRP algorithm ensures a standardized and effective approach to neonatal resuscitation, minimizing the risk of error and maximizing the chance of a positive outcome. Incorrect approaches analysis. One incorrect approach would be to continue PPV indefinitely without reassessing the heart rate or considering chest compressions, even if the infant's condition is not improving. This fails to recognize that PPV alone may be insufficient and that other interventions are necessary. This approach violates NRP guidelines by not progressing through the algorithm appropriately and could lead to delayed or absent chest compressions, which are crucial for improving cardiac output when the heart rate is critically low. Another incorrect approach would be to immediately initiate chest compressions without first ensuring adequate ventilation. The NRP algorithm clearly states that effective PPV is the first step in resuscitation for most term infants with apnea or gasping. Initiating compressions prematurely without adequate ventilation is not supported by the evidence and can be less effective than addressing the primary issue of ventilation. This represents a failure to follow the established resuscitation sequence and could lead to a less effective resuscitation effort. A third incorrect approach would be to focus solely on the performance metric of sustained chest compressions, without addressing the underlying reason for the lack of sustained compressions, such as inadequate ventilation or a failure to recognize the need for them. This reactive approach, rather than a proactive adherence to the algorithm, can lead to continued suboptimal care. It fails to address the root cause of the performance issue and deviates from the systematic decision-making process mandated by NRP. Professional reasoning. Professionals should utilize the NRP algorithm as their primary decision-making framework. This involves a continuous cycle of assessment, intervention, and reassessment. When faced with a scenario like this, the team must 1. Assess the infant's breathing and heart rate. 2. If apneic or gasping, initiate PPV. 3. Ensure PPV is effective chest rise. 4. Reassess heart rate after 30 seconds of effective PPV. 5. If heart rate is 60 BPM despite effective PPV, initiate chest compressions coordinated with PPV. 6. Continuously evaluate the infant's response and adjust interventions accordingly. This systematic approach ensures that the most critical interventions are performed in the correct sequence and at the appropriate time. Question 9. Research into Neonatal Resuscitation Program, NRP, certification guidelines indicates that during resuscitation of a term infant with apnea and bradycardia that is not improving with positive pressure ventilation, PPV, what is the most appropriate next step regarding airway management? Option A. Continue PPV with a mask, adjusting the pressure and ensuring a good seal, while reassessing the infant's heart rate and oxygenation. Option B. Administer chest compressions to improve cardiac output and circulation. Option C. Proceed with endotracheal intubation to secure the airway and facilitate effective ventilation. Option D. Obtain a chest X-ray to rule out any congenital anomalies affecting respiration. The correct answer is C. Proceed with endotracheal intubation to secure the airway and facilitate effective ventilation. Explanation. This scenario is professionally challenging due to the critical nature of neonatal resuscitation and the immediate need for effective airway management. The infant's condition necessitates rapid, accurate decision-making under pressure, where any delay or incorrect procedure can have severe consequences. The decision to intubate is a significant intervention requiring a thorough assessment of the infant's status and the potential benefits versus risks. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based assessment of the infant's need for endotracheal intubation, aligning with the Neonatal Resuscitation Program, NRP guidelines. This involves evaluating the effectiveness of positive pressure ventilation, PPV, and considering specific indications for intubation, such as persistent bradycardia despite PPV, need for prolonged PPV, or administration of surfactant. Adherence to NRP protocols ensures a standardized, safe, and effective approach to neonatal resuscitation, minimizing the risk of complications and optimizing the infant's outcome. An incorrect approach that proceeds directly to intubation without first assessing the effectiveness of PPV fails to follow the NRP algorithm. This bypasses a crucial step that might resolve the infant's respiratory distress, exposing the infant to the risks of intubation, e.g., trauma, hypoxemia, esophageal intubation, unnecessarily. This also represents a failure to adhere to established resuscitation guidelines, which are designed to ensure the most appropriate intervention is performed at the right time. Another incorrect approach, delaying intubation despite clear indications and ongoing deterioration, is also professionally unacceptable. This failure to act decisively when intubation is indicated can lead to prolonged hypoxemia and acidosis, worsening the infant's condition and potentially leading to irreversible harm. This demonstrates a breakdown in clinical judgment and a failure to apply the principles of timely and effective resuscitation as outlined by NRP. The professional decision-making process for similar situations should involve a rapid, yet thorough, assessment of the infant's condition, including heart rate, respiratory effort, and response to initial interventions. Clinicians must be proficient in recognizing the signs and symptoms that warrant endotracheal intubation, according to NRP guidelines. This involves a continuous evaluation of the infant's status and a willingness to adapt the resuscitation strategy based on the infant's response. A structured approach, such as the NRP algorithm, provides a framework for making these critical decisions, ensuring that interventions are evidence-based and delivered in a timely and appropriate manner. Question 10. Process analysis reveals that term infant is born covered in meconium-stained amniotic fluid. The infant is not crying vigorously and has some muscle tone. Based on the Neonatal Resuscitation Program, NRP, guidelines, what is the most appropriate initial step? Option A. Begin positive pressure ventilation immediately due to meconium staining. Option B. Suction the oropharynx and nasopharynx before any other intervention. Option C. Wait for the infant to cry spontaneously before performing any assessment. Option D. Dry the infant, provide tactile stimulation, and assess breathing, tone, and heart rate. The correct answer is A. Begin positive pressure ventilation immediately due to meconium staining. Explanation. This scenario is professionally challenging because the initial moments after birth are critical for identifying infants who require resuscitation and initiating the correct interventions promptly. The pressure of a potentially compromised infant, coupled with the need for rapid assessment and action, demands precise adherence to established protocols. The core of the challenge lies in accurately assessing the infant's condition based on objective criteria, and then selecting the appropriate initial steps, avoiding premature or unnecessary interventions. The correct approach represents best professional practice because it aligns directly with the Neonatal Resuscitation Program, NRP guidelines, which are evidence-based and designed to optimize outcomes for newborns. Specifically, the NRP emphasizes a systematic assessment of breathing, heart rate, and tone to determine the need for positive pressure ventilation, PPV, or chest compressions. This structured approach ensures that interventions are initiated only when indicated, minimizing potential harm from unnecessary procedures and maximizing the effectiveness of necessary ones. Adhering to these guidelines is a regulatory and ethical imperative, as it reflects the standard of care expected in neonatal resuscitation. An incorrect approach, such as initiating PPV solely based on the presence of meconium staining, without a thorough assessment of the infant's respiratory effort and tone, represents a failure to follow the NRP algorithm. The current NRP guidelines do not recommend routine PPV for all infants with meconium staining. The decision is based on the infant's clinical condition. Another incorrect approach, such as delaying drying and stimulation because the infant appears vigorous, would be a failure to perform essential initial steps that can often improve the infant's transition. Furthermore, assuming the infant will cry spontaneously, and therefore not assessing the heart rate would be a critical oversight, as a low heart rate is a primary indicator for intervention. These failures violate the established protocols and could lead to delayed or inappropriate care, potentially harming the infant. Professional decision-making in similar situations requires a systematic, algorithm-driven approach. Professionals must be proficient in the NRP guidelines, able to quickly and accurately assess the infant's key physiological parameters, breathing, heart rate, tone, color, and confidently apply the appropriate steps based on that assessment. Regular training, simulation, and a commitment to continuous learning are essential to maintain this proficiency. The focus should always be on objective assessment and adherence to the established resuscitation algorithm. Question 11. The efficiency study reveals that in a term neonate presenting with apnea and a heart rate of 80 beats per minute, the most rapid and effective intervention to improve oxygenation and ventilation is to: Option A. Administer supplemental oxygen via a non-rebreather mask. Option B. Begin chest compressions while awaiting further assessment. Option C. Proceed directly with endotracheal intubation to secure the airway. Option D. Immediately initiate positive pressure ventilation using a mask and bag, ensuring adequate chest rise. The correct answer is D. Immediately initiate positive pressure ventilation using a mask and bag, ensuring adequate chest rise. Explanation. The efficiency study reveals that the speed of initiating positive pressure ventilation, PPV, in a neonate with suspected apnea is a critical factor in patient outcomes. This scenario is professionally challenging because the provider must quickly assess the need for PPV and select the most appropriate airway management technique under pressure, balancing speed with effectiveness and safety. The Neonatal Resuscitation Program, NRP certification, emphasizes a systematic approach to resuscitation, prioritizing interventions based on the neonate's condition. The correct approach, which involves assessing the need for PPV based on the neonate's respiratory effort and heart rate, and then initiating PPV with a mask and bag, represents best professional practice according to NRP guidelines. This aligns with the core principles of NRP, which prioritize effective ventilation as the cornerstone of neonatal resuscitation. The NRP algorithm clearly outlines the steps for initiating PPV, emphasizing the importance of a good mask seal and adequate chest rise as indicators of effective ventilation. This systematic, evidence-based approach minimizes delays and ensures that the neonate receives the most critical intervention promptly and effectively. Initiating PPV without first assessing the neonate's respiratory effort and heart rate is a regulatory and ethical failure. NRP guidelines mandate a structured assessment to determine if PPV is indicated. Performing PPV on a neonate who is breathing effectively could lead to unnecessary interventions. Potential harm, e.g., gastric distension, barotrauma, and delays in addressing the actual underlying issue if it's not respiratory depression. Similarly, attempting to intubate the trachea as the initial step for a neonate who simply requires PPV is also a failure. Intubation is a more invasive procedure with its own risks and is indicated for specific reasons outlined in NRP, such as failure to achieve adequate ventilation with a mask, or the need for prolonged ventilation or medications. Performing intubation prematurely bypasses the simpler, less invasive, and often equally effective method of mask PPV, which is the first-line intervention for respiratory depression or apnea. The professional decision-making process for similar situations should follow the NRP algorithm strictly. This involves a rapid assessment of the neonate's tone, respiratory effort, and heart rate. If the neonate is apneic or gasping and has a heart rate below 100 beats per minute, PPV is indicated. The provider should then ensure a proper mask seal and initiate PPV, observing for chest rise. If chest rise is inadequate, troubleshooting steps for mask PPV should be performed before considering alternative advanced airway techniques. This systematic approach ensures that the most appropriate and effective intervention is delivered in a timely manner, adhering to established resuscitation protocols. Question 12. Which approach would be most consistent with the Neonatal Resuscitation Program, NRP, guidelines when assessing and managing a term infant who is apneic at birth and has a heart rate of 50 beats per minute? Option A. Assess the infant's oxygen saturation levels before considering any resuscitation measures. Option B. Continue to stimulate the infant for another 30 seconds to see if spontaneous breathing returns. Option C. Immediately initiate positive pressure ventilation while ensuring adequate chest rise. Option D. Begin chest compressions and administer epinephrine without first attempting positive pressure ventilation. The correct answer is C. Immediately initiate positive pressure ventilation while ensuring adequate chest rise. Explanation. The scenario of a neonate requiring resuscitation presents a critical, time-sensitive situation where immediate and effective action is paramount. The challenge lies in the rapid assessment of the infant's condition, the accurate identification of the need for intervention, and the precise execution of resuscitation steps according to established guidelines. Failure to act appropriately can have severe, life-altering consequences for the infant. The correct approach, which aligns with the Neonatal Resuscitation Program, NRP, guidelines, emphasizes a systematic and evidence-based process. This involves initial steps such as warming, positioning, clearing the airway if necessary, and stimulating the infant. If these initial steps do not result in adequate breathing and heart rate, positive pressure ventilation, PPV, is initiated. The decision to proceed to chest compressions and medications is based on a thorough assessment of the heart rate and chest rise, ensuring that interventions are only applied when indicated and are performed correctly. This approach represents best professional practice because it is designed to optimize the infant's chances of survival and minimize the risk of complications by adhering to the most current, scientifically validated resuscitation protocols. The NRP certification itself signifies a commitment to mastering these specific guidelines. An incorrect approach would be to delay initiating PPV despite signs of inadequate breathing or bradycardia, perhaps due to uncertainty or a desire to observe further. This delay directly contravenes the NRP's emphasis on prompt intervention when indicated, potentially leading to irreversible hypoxic injury. Another incorrect approach would be to administer chest compressions without a documented heart rate below 60 beats per minute, or without ensuring adequate ventilation has been established first, as this is not supported by NRP guidelines and can be detrimental. Furthermore, administering medications without a clear indication and proper assessment of the infant's response to other interventions would also be a failure to adhere to best practices and could lead to adverse effects. Professionals should approach neonatal resuscitation by first recalling and applying the core principles of the NRP algorithm. This involves a structured assessment of the infant's tone, breathing, and heart rate. If the infant is apneic or gasping, and the heart rate is low, PPV is the immediate next step. The effectiveness of PPV is then assessed by observing chest rise and reassessing the heart rate. If the heart rate remains below 60 beats per minute despite effective PPV, chest compressions are initiated. Throughout the process, continuous reassessment and adaptation based on the infant's response are crucial. This systematic, algorithm-driven approach, honed through NRP certification and ongoing education, ensures that interventions are timely, appropriate, and delivered with the highest probability of success. Question 13. The review process indicates a need to clarify the appropriate use of medications during neonatal resuscitation. A 30-week gestation neonate is born via emergency cesarean section and is apneic with a heart rate of 50 beats per minute despite effective positive pressure ventilation and chest compressions. What is the most appropriate next step regarding medication administration? Option A. Administer epinephrine intratracheally. Option B. Administer a fluid bolus intravenously. Option C. Administer epinephrine intravenously. Option D. Administer a surfactant bolus intratracheally. The correct answer is C. Administer epinephrine intravenously. Explanation. The review process indicates a need to reinforce understanding of medication indications in neonatal resuscitation, a critical skill that demands precise application of established guidelines. This scenario is professionally challenging because it requires rapid, accurate assessment of a neonate's condition and a thorough understanding of when pharmacological intervention is indicated, balancing the potential benefits against the risks of unnecessary medication. The pressure of a resuscitation event can amplify the cognitive load, making adherence to evidence-based protocols paramount. The correct approach represents best professional practice because it aligns directly with the Neonatal Resuscitation Program, NRP, guidelines, which are the established standard of care in the United States for neonatal resuscitation. These guidelines are developed through rigorous scientific review and expert consensus, ensuring that interventions are evidence-based and aimed at optimizing outcomes while minimizing harm. Administering epinephrine intravenously for persistent bradycardia, despite adequate ventilation and chest compressions, is a cornerstone of NRP, directly addressing a life-threatening condition that is unlikely to resolve with non-pharmacological measures alone. This adheres to the principle of providing timely and appropriate medical care as dictated by the neonate's physiological status. Administering epinephrine without confirming adequate ventilation and chest compressions is a regulatory and ethical failure. The NRP emphasizes that chest compressions and ventilation are the primary interventions for bradycardia and hypoxemia. Introducing epinephrine prematurely bypasses these essential steps, potentially masking the underlying cause of the bradycardia and delaying crucial respiratory and circulatory support. This deviates from the stepwise approach mandated by NRP and could lead to inappropriate treatment and adverse outcomes. Administering a fluid bolus for bradycardia without evidence of hypovolemia is also a failure. While fluid boluses can be considered in specific circumstances, such as suspected hypovolemic shock contributing to bradycardia, they are not a first-line intervention for bradycardia in the absence of such indicators. The NRP guidelines prioritize other interventions for bradycardia. Administering fluids without a clear indication represents a deviation from evidence-based practice and introduces unnecessary risk, such as fluid overload. Administering a surfactant bolus for bradycardia is a significant regulatory and ethical failure. Surfactant is indicated for respiratory distress syndrome in preterm infants, not for bradycardia. Administering surfactant in this context is entirely inappropriate, lacks any scientific or clinical rationale for treating bradycardia, and exposes the neonate to potential harm from an unnecessary and incorrectly administered medication. This demonstrates a fundamental misunderstanding of neonatal pharmacology and resuscitation protocols. The professional decision-making process for similar situations should involve a systematic algorithm-driven approach. This includes 1. Rapidly assessing the neonate's heart rate and respiratory effort. 2. Ensuring adequate ventilation and chest compressions if indicated by the heart rate. 3. Considering reversible causes of bradycardia. 4. Following the NRP algorithm precisely, which dictates the sequence of interventions, including the timely administration of epinephrine when indicated by persistent bradycardia, despite optimal non-pharmacological support. Continuous review of the neonate's response to interventions and adherence to established guidelines are critical for effective and safe neonatal resuscitation. Question 14. The analysis reveals that a neonate undergoing resuscitation is unresponsive to initial steps, including positive pressure ventilation and chest compressions, with a heart rate remaining below 60 beats per minute. The decision is made to administer medication. Which of the following represents the most appropriate pharmacological intervention and route of administration according to the Neonatal Resuscitation Program guidelines? Option A. Normal saline bolus via umbilical venous catheter. Option B. Sodium bicarbonate via umbilical venous catheter. Option C. Epinephrine via umbilical venous catheter. Option D. Atropine via umbilical venous catheter. The correct answer is C. Epinephrine via umbilical venous catheter. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in neonatal resuscitation: the administration of medications when the neonate's condition is unstable and rapid decision-making is paramount. The professional challenge lies in accurately identifying the correct medication, dosage, and route of administration under extreme time pressure, while also considering potential adverse effects and the neonate's specific physiological status. Misjudgment can have immediate and severe consequences for the infant's survival and long-term health. Correct approach analysis. The correct approach prioritizes the immediate and accurate administration of epinephrine via the umbilical venous catheter. This aligns with established Neonatal Resuscitation Program (NRP) guidelines, which are the sole regulatory framework for this certification. Epinephrine is the first-line medication for asystole or profound bradycardia, unresponsive to initial steps. The umbilical venous catheter is the preferred route for rapid vascular access in neonates during resuscitation, ensuring swift delivery of the medication to the central circulation. This approach demonstrates adherence to evidence-based practice and regulatory mandates for neonatal resuscitation, prioritizing patient safety and optimal outcomes. Incorrect approaches analysis. Administering a bolus of normal saline without confirming the presence of hypovolemia is an incorrect approach. While fluid boluses can be considered for suspected hypovolemia, they are not the first-line treatment for asystole or profound bradycardia unresponsive to ventilation and chest compressions. Delaying epinephrine administration in favor of fluids when the primary issue is cardiac arrest or severe bradycardia represents a failure to follow established resuscitation algorithms and can lead to a critical delay in life-saving treatment. Administering a dose of sodium bicarbonate without confirming persistent metabolic acidosis is also incorrect. Sodium bicarbonate is a second-line medication, indicated only after prolonged resuscitation efforts and confirmed metabolic acidosis, and its administration can have adverse effects such as hypernatremia and paradoxical central nervous system acidosis. Administering it prematurely or without clear indication deviates from standard resuscitation protocols and can be detrimental. Administering a dose of atropine is incorrect in this specific scenario. Atropine is indicated for symptomatic bradycardia due to increased vagal tone, which is less common in neonatal arrest compared to other causes. Epinephrine is the primary intervention for bradycardia unresponsive to ventilation and chest compressions, and atropine would be a deviation from the established algorithm. Professional reasoning. Professionals must approach such situations by systematically applying the NRP algorithm. This involves a rapid assessment of the neonate's condition, identification of the underlying problem e.g. asystole, bradycardia, and then selecting the appropriate intervention based on the algorithm's stepwise approach. This includes confirming adequate ventilation and chest compressions, establishing vascular access, and administering the correct medication at the correct dose and via the correct route. Continuous reassessment and adaptation of the resuscitation strategy based on the neonate's response are crucial. Adherence to the NRP guidelines is not merely a procedural step, but a critical ethical and regulatory obligation to provide the highest standard of care. Question 15. The control framework reveals that when managing a neonate born through meconium-stained amniotic fluid who is not vigorous and has visible airway obstruction, the decision to use suctioning devices requires a careful risk assessment. Which of the following approaches best reflects current neonatal resuscitation program, NRP, guidelines and best professional practice in this scenario? Option A. Immediately initiate suctioning with a suction catheter connected to wall suction at 100 mmHg, regardless of the infant's response to initial steps. Option B. Perform routine suctioning of the mouth and nose with a bulb syringe for all infants born through meconium-stained fluid, even if they appear vigorous. Option C. Assess for visible airway obstruction and, if present, gently suction the mouth and then the nose with a bulb syringe or suction catheter, only if the infant is not vigorous and continues to have signs of obstruction. Option D. Delay any suctioning until positive pressure ventilation has been initiated and the infant's oxygen saturation improves. The correct answer is A. Immediately initiate suctioning with a suction catheter connected to wall suction at 100 mmHg, regardless of the infant's response to initial steps. Explanation. The control framework reveals that the use of suctioning devices in neonatal resuscitation is a critical intervention that requires careful risk assessment due to the potential for harm if not performed correctly. The professional challenge lies in balancing the need to clear the airway of meconium or other obstructions with the risk of bradycardia, hypoxemia, or trauma to delicate neonatal tissues. A thorough understanding of the current neonatal resuscitation program, NRP, guidelines is paramount. The correct approach prioritizes the least invasive and most effective method based on the neonate's condition. Current NRP guidelines emphasize that routine suctioning of the mouth and nose is generally not recommended for vigorous newborns born through meconium-stained amniotic fluid. However, if the airway is visibly obstructed or the infant is not vigorous, suctioning may be indicated. The risk assessment involves evaluating the infant's tone, respiratory effort, and heart rate. The correct approach involves using a bulb syringe or a suction catheter connected to gentle suction, only when indicated by the infant's condition, and performing it swiftly to minimize interruption of positive pressure ventilation if already initiated. This aligns with the NRP's focus on evidence-based practice and minimizing unnecessary interventions that could cause harm. An incorrect approach would be to routinely suction all infants born through meconium-stained fluid, regardless of their vigor or the presence of visible obstruction. This is a regulatory failure as it deviates from current NRP guidelines, which are the established standard of care for neonatal resuscitation in the U.S. Ethically, it represents a failure to adhere to the principle of do no harm by potentially inducing bradycardia or hypoxemia through unnecessary stimulation or prolonged procedures. Another incorrect approach would be to use excessive suction pressure or to suction aggressively. This poses a significant risk of mucosal trauma, vagal stimulation leading to bradycardia, and hypoxemia due to the removal of air from the lungs. This is a failure to apply the device appropriately and safely, violating the core principles of neonatal resuscitation and the specific instructions within the NRP for device use. A third incorrect approach would be to delay suctioning when there is a clear indication of airway obstruction in a non-vigorous infant. This delay can lead to worsening hypoxemia and acidosis, potentially impacting neurological outcomes. This is a failure in timely and appropriate intervention, directly contradicting the goal of resuscitation. The professional decision-making process for similar situations should involve a systematic assessment of the infant's condition using the ABCs: airway, breathing, circulation, and the initial steps of resuscitation. This includes evaluating the infant's tone, respiratory effort, and heart rate. If meconium is present and the infant is not vigorous, the decision to suction should be based on the presence of visible airway obstruction or signs of compromised breathing. The chosen suctioning device and technique should be appropriate for the infant's gestational age and condition, and the procedure should be performed efficiently and with minimal interruption to other resuscitation efforts. Continuous reassessment of the infant's response is crucial. Question 16. Strategic planning requires a healthcare team to anticipate potential complications during neonatal resuscitation. If a neonate presents with persistent hypotension and signs of poor perfusion, despite initial resuscitation efforts, and hypovolemia is strongly suspected, which of the following represents the most appropriate initial volume expansion strategy according to current neonatal resuscitation program, NRP guidelines? Option A. Immediate administration of a hypertonic solution such as 5% sodium bicarbonate to rapidly increase intravascular volume. Option B. Administration of a colloid solution such as albumin as the primary volume expander in the absence of crystalloids. Option C. Administration of an isotonic crystalloid solution such as normal saline or Ringer's lactate in a bolus of 10 ml/kg over 5-10 minutes, followed by reassessment. Option D. Infusion of a hypotonic solution such as 5% dextrose in water D5W to provide hydration and support circulation. The correct answer is C. Administration of an isotonic crystalloid solution, such as normal saline or Ringer's lactate, in a bolus of 10 ml/kg over 5-10 minutes, followed by reassessment. Explanation: the administration of volume expanders in neonatal resuscitation is a critical intervention, often necessitated by suspected hypovolemic shock. This scenario is professionally challenging because it requires rapid assessment, accurate diagnosis of the underlying cause of hypotension, and timely, appropriate intervention while considering the neonate's fragile physiological state. Misjudging the indication or administering the wrong type or volume of fluid can lead to significant harm, including fluid overload, pulmonary edema, or exacerbation of existing conditions. The correct approach, which involves administering isotonic crystalloids like normal saline or Ringer's lactate, represents best professional practice because these agents are readily available, generally safe, and effective in temporarily improving intravascular volume and tissue perfusion in hypovolemic neonates. Guidelines from the Neonatal Resuscitation Program, NRP, emphasize their use as a first-line volume expander when hypovolemia is suspected and initial resuscitation measures have not restored adequate circulation. This aligns with the principle of providing necessary support to stabilize the neonate while further diagnostic evaluation or definitive treatment is initiated. An incorrect approach would be to administer hypotonic solutions, such as 5% dextrose in water D5W. This is professionally unacceptable because hypotonic solutions can shift fluid into the intracellular space, potentially worsening cerebral edema and failing to effectively expand the intravascular volume. Another incorrect approach is to administer colloids without a clear indication or in the absence of isotonic crystalloids. While colloids can expand plasma volume more effectively, their use in routine neonatal resuscitation for suspected hypovolemia is not universally recommended and may carry risks, such as allergic reactions or effects on coagulation, and are generally reserved for specific situations or when crystalloids are insufficient. Administering a large bolus of any fluid without reassessment of the neonate's response is also professionally unsound. It fails to acknowledge the dynamic nature of the neonate's condition and the importance of monitoring for efficacy and potential adverse effects, such as signs of fluid overload. The professional decision-making process for similar situations should involve a systematic approach. First, rapidly assess the neonate's hemodynamic status, looking for signs of poor perfusion e.g., pale or mottled skin, weak pulses, delayed capillary refill, decreased urine output, and hypotension. Second, consider potential causes of hypotension, differentiating between hypovolemia, sepsis, cardiac dysfunction, or other etiologies. Third, if hypovolemia is strongly suspected and initial measures are insufficient, administer an appropriate volume expander e.g., isotonic crystalloid as per NRP guidelines. Fourth, closely monitor the neonate's response to the intervention, including vital signs, perfusion, and signs of fluid overload. Fifth, reassess and adjust the management plan based on the response and ongoing assessment. This iterative process ensures that interventions are evidence-based, tailored to the individual neonate, and continuously evaluated for effectiveness and safety. Question 17. During the evaluation of a term infant born via emergency cesarean section due to fetal distress, initial resuscitation efforts including positive pressure ventilation and chest compressions are underway. Despite these interventions, the infant remains bradycardic with poor perfusion. The team is considering administering sodium bicarbonate and calcium. Based on the Neonatal Resuscitation Program, NRP guidelines, what is the most appropriate next step in managing this infant's cardiovascular compromise? Option A. Immediately intubate the infant and administer epinephrine to improve cardiac contractility. Option B. Obtain a blood gas analysis to confirm severe metabolic acidosis before considering any medication. Option C. Reevaluate and optimize the effectiveness of positive pressure ventilation and chest compressions, ensuring adequate ventilation and circulation before considering pharmacological interventions. Option D. Administer sodium bicarbonate and calcium to address potential metabolic acidosis and hypocalcemia contributing to the bradycardia. The correct answer is D. Administer sodium bicarbonate and calcium to address potential metabolic acidosis and hypocalcemia contributing to the bradycardia. Explanation: this scenario is professionally challenging because it requires the resuscitation team to critically assess the infant's condition and the effectiveness of initial resuscitation efforts before considering the administration of medications like sodium bicarbonate and calcium. The decision to administer these medications is not routine and is guided by specific clinical indicators and evidence-based guidelines, primarily to address metabolic acidosis that is refractory to ventilation and chest compressions, or severe hypocalcemia. The Neonatal Resuscitation Program, NRP, guidelines, which are the sole regulatory framework for this exam, emphasize that these medications are typically considered only after adequate ventilation and chest compressions have been established, and their effectiveness is being evaluated. The correct approach represents best professional practice because it adheres strictly to the NRP guidelines. These guidelines prioritize basic steps of resuscitation, ventilation, and chest compressions, and advocate for their optimization before introducing pharmacological interventions. Sodium bicarbonate is indicated for documented metabolic acidosis, pH 700, that is unresponsive to effective ventilation and chest compressions, or in specific situations like known maternal history of diabetes or certain drug ingestions. Calcium is indicated for suspected or documented hypocalcemia, which can manifest as poor cardiac contractility or arrhythmias, especially in preterm infants or those with conditions like asphyxia. Administering these medications without a clear indication or before optimizing ventilation and compressions can be detrimental, potentially leading to adverse effects such as hypernatremia, hyperosmolality, or worsening acidosis. An incorrect approach of administering sodium bicarbonate and calcium empirically without assessing the effectiveness of ventilation and chest compressions, or without clear indications of metabolic acidosis or hypocalcemia, represents a significant regulatory and ethical failure. This deviates from the NRP's evidence-based approach, which prioritizes the least invasive and most effective interventions first. Such an action could be considered a deviation from the standard of care, potentially causing harm to the infant and violating the ethical principle of beneficence, acting in the patient's best interest. Furthermore, it demonstrates a lack of critical assessment and adherence to established resuscitation protocols. The professional reasoning process for similar situations involves a systematic, stepwise approach guided by the NRP algorithm. This includes 1. Assessing the need for resuscitation, 2. Initiating and optimizing positive pressure ventilation, PPV, and chest compression, 3. Continuously evaluating the infant's response to these interventions, heart rate, tone, color, 4. Considering advanced airway management if PPV is ineffective, and 5. Only then, based on specific clinical findings and the infant's response, considering medications like sodium bicarbonate and calcium, ensuring their administration is appropriate for the identified clinical problem and aligns with current NRP guidelines. Question 18. The monitoring system demonstrates a slight decrease in the newborn's spontaneous limb movements and a subtle increase in muscle tone during routine observation. Which of the following approaches best reflects a comprehensive neurological assessment in this context, according to Neonatal Resuscitation Program certification guidelines? Option A. Focus primarily on the infant's crying and feeding patterns, as these are the most reliable indicators of neurological well-being. Option B. Perform a detailed assessment of the infant's reflexes, including grasp, moro, and sucking reflexes, alongside evaluating muscle tone and spontaneous activity. Option C. Rely on the parent's report of the infant's usual activity levels to determine if the observed changes are significant. Option D. Immediately initiate pharmacological interventions to address the perceived changes in tone and movement. The correct answer is B. Perform a detailed assessment of the infant's reflexes, including grasp, moro, and sucking reflexes, alongside evaluating muscle tone and spontaneous activity. Explanation. The monitoring system demonstrates a subtle but significant change in the newborn's behavior, requiring a nuanced neurological assessment. This scenario is professionally challenging because the observed changes are not overtly alarming, but could indicate an underlying neurological issue that, if missed, could have long-term consequences for the infant's development. The urgency lies in differentiating between normal neonatal variability and signs of distress or dysfunction. The correct approach represents best professional practice because it aligns with the Neonatal Resuscitation Program, NRP, guidelines, which emphasize a systematic and comprehensive neurological assessment. This includes evaluating tone, reflexes, and responsiveness in a structured manner. By comparing the current findings to established norms and the infant's baseline, healthcare providers can accurately identify deviations and initiate appropriate interventions. This proactive and evidence-based approach ensures the infant receives timely and necessary care, adhering to the ethical principle of beneficence and the regulatory mandate to provide high-quality neonatal care. An incorrect approach that focuses solely on gross motor movements without assessing finer neurological signs, such as reflexes or muscle tone, fails to capture the full picture of the infant's neurological status. This oversight could lead to a misdiagnosis of a subtle neurological impairment, violating the duty of care and potentially contravening regulatory requirements for thorough patient assessment. Another incorrect approach that relies on parental subjective reports without objective clinical assessment is also professionally unacceptable. While parental input is valuable, it cannot replace a skilled clinical evaluation. Relying solely on subjective information risks misinterpreting the infant's condition, potentially delaying necessary medical attention, and failing to meet the standards of care expected in neonatal practice. A third incorrect approach that involves immediate, aggressive intervention based on minimal, ambiguous findings without a systematic assessment is also problematic. While prompt action is crucial in neonatology, it must be guided by a clear understanding of the infant's neurological status. Premature or unnecessary interventions can cause harm and do not reflect the evidence-based decision-making process mandated by NRP guidelines. The professional decision-making process for similar situations should involve a systematic approach. First, observe and gather objective data through a structured neurological assessment. Second, compare these findings to established norms and the infant's baseline. Third, consider the clinical context and any contributing factors. Fourth, consult with colleagues or specialists if uncertainty exists. And finally, document all findings and interventions meticulously. This process ensures that decisions are informed, evidence-based, and in the best interest of the infant, adhering to all relevant regulatory and ethical standards. Question 19. The risk matrix shows a high probability of communication breakdown and task duplication during neonatal resuscitation if roles are not explicitly defined. In a situation where a neonate requires immediate resuscitation, what is the most effective approach to ensure efficient and coordinated team performance? Option A. The most experienced clinician directs all actions while other team members wait for specific instructions. Option B. Team members are expected to assume roles based on their seniority and perceived expertise without explicit assignment. Option C. The team leader clearly assigns specific roles and responsibilities to each team member at the outset of the resuscitation. Option D. Individuals are encouraged to volunteer for specific tasks as the resuscitation progresses. The correct answer is C. The team leader clearly assigns specific roles and responsibilities to each team member at the outset of the resuscitation. Explanation. Scenario analysis. This scenario is professionally challenging because effective neonatal resuscitation hinges on precise, coordinated actions by a multidisciplinary team under immense time pressure. Misunderstanding or failing to clearly define roles and responsibilities can lead to critical delays, duplicated efforts, or missed essential steps, directly impacting the neonate's outcome. The inherent stress of a resuscitation event amplifies the need for pre-established clarity and adherence to established protocols. Correct approach analysis. The correct approach, where the team leader clearly assigns specific roles and responsibilities at the outset of the resuscitation, represents best professional practice. This aligns with the Neonatal Resuscitation Program, NRP guidelines, which emphasize structured team dynamics and clear communication. By designating individuals for tasks such as ventilation, chest compressions, medication administration, and documentation, the team can operate efficiently and without confusion. This structured approach minimizes the risk of errors, ensures all critical steps are addressed promptly, and allows for continuous assessment and adaptation of the resuscitation strategy. It fosters accountability and allows team members to focus on their assigned duties, optimizing the overall resuscitation effort. Incorrect approaches analysis. Assuming individuals will naturally assume roles based on seniority or perceived expertise without explicit assignment is a significant regulatory and ethical failure. This ad hoc approach contradicts NRP principles of structured teamwork and can lead to a lack of accountability, duplicated efforts, or critical tasks being overlooked. It creates an environment ripe for confusion and delays, directly jeopardizing patient safety. Allowing the most experienced clinician to direct all actions without delegating specific tasks, even to less experienced but capable team members, is also a failure. While experience is valuable, this approach can overload the senior clinician, leading to burnout and potential errors. It also fails to leverage the skills of other team members and hinders their development and participation in critical care. This can be seen as a failure to optimize team resources and a potential violation of the principle of shared responsibility in emergency care. Waiting for individuals to volunteer for specific tasks during the resuscitation is another critical failure. In a high-stress, time-sensitive situation, hesitation or uncertainty about who should perform a task can result in dangerous delays. This reactive approach is contrary to the proactive, structured nature of effective resuscitation and can lead to a breakdown in coordinated care, directly impacting the neonate's chances of survival and recovery. Professional reasoning. Professionals should employ a structured decision-making process that prioritizes clear communication and role clarity from the moment a resuscitation is anticipated or initiated. This involves 1. Recognizing the need for a resuscitation team. 2. Proactively identifying and assigning specific roles and responsibilities based on the situation and available personnel, ideally before the most critical interventions begin. 3. Ensuring open communication channels throughout the event, allowing for reassignment of roles if necessary. 4. Regularly assessing team performance and patient status to adapt the resuscitation strategy. This systematic approach, grounded in established resuscitation guidelines, ensures optimal team function and patient care. Question 20. Regulatory review indicates that a neonate presents with cyanosis and tachypnea shortly after birth. The resuscitation team is considering the initial administration of supplemental oxygen. Which of the following approaches best aligns with current Neonatal Resuscitation Program, NRP, guidelines for managing this situation? Option A. Assess the neonate's oxygen saturation using a pulse oximeter and administer supplemental oxygen at the lowest effective concentration to achieve target saturation. Option B. Wait to administer supplemental oxygen until the neonate's condition deteriorates further to avoid potential oxygen toxicity. Option C. Immediately administer 100% oxygen via a mask and bag, as the cyanosis indicates a severe oxygen deficit. Option D. Begin positive pressure ventilation with 100% oxygen without first assessing the neonate's baseline oxygen saturation. The correct answer is A. Assess the neonate's oxygen saturation using a pulse oximeter and administer supplemental oxygen at the lowest effective concentration to achieve target saturation. Explanation. This scenario is professionally challenging because the decision regarding supplemental oxygen for a neonate requires a delicate balance between providing necessary support and avoiding potential harm. The neonate's clinical presentation, specifically the presence of cyanosis and tachypnea, indicates a potential need for oxygen, but the exact concentration and delivery method must be carefully titrated. Overoxygenation can lead to retinopathy of prematurity (ROP) and other adverse effects, while insufficient oxygen can result in hypoxic injury. Therefore, Precise adherence to established NRP guidelines is paramount. The correct approach, which involves assessing the neonate's oxygen saturation and administering supplemental oxygen at the lowest effective concentration to achieve target saturation, represents best professional practice. This aligns directly with the Neonatal Resuscitation Program, NRP, guidelines, which emphasize a stepwise approach to oxygen administration. The NRPs focus on target saturation ranges e.g. 90–95% for term and preterm infants after the first few minutes of life, is a critical regulatory and evidence-based mandate designed to optimize outcomes and minimize risks. This approach is proactive, evidence-based, and patient-centered, ensuring that the neonate receives the precise level of support needed. Administering a high concentration of oxygen without initial assessment is a significant regulatory and ethical failure. It bypasses the NRP's structured approach to oxygenation, increasing the risk of oxygen toxicity and ROP, which are well-documented adverse outcomes. This approach is reactive and potentially harmful, failing to adhere to the principle of do no harm. Initiating positive pressure ventilation with 100% oxygen immediately without first attempting to assess the need for oxygen or titrate the concentration is also a failure. While PPV may be necessary, the NRP guidelines advocate for starting with room air or a lower concentration of oxygen if the neonate is not apneic or bradycardic, and only increasing the concentration if the response is inadequate. This approach risks unnecessary exposure to high oxygen concentrations. Delaying oxygen administration until the neonate is severely compromised is another failure. While avoiding overoxygenation is important, delaying necessary oxygen can lead to irreversible hypoxic injury. The NRP emphasizes prompt recognition of hypoxemia and appropriate intervention. Professional decision-making in such situations requires a systematic approach. First, assess the neonate's condition, including color, heart rate, and respiratory effort. Second, consult the NRP algorithm for guidance on initial steps, including oxygen administration. Third, if oxygen is indicated, use a pulse oximeter to monitor oxygen saturation and titrate the inspired oxygen concentration to achieve the target saturation range. Fourth, continuously reassess the neonate's response and adjust interventions as needed. This iterative process ensures that care is both responsive and evidence-based, adhering to regulatory requirements and ethical obligations.